Okay, so I would like to acknowledge the traditional owners and custodians of the land we're all on today. So today I'm coming to you from our Women's Health New South Wales office. So that's here on Gadigal land. I also recognise that many of you are coming from different lands across Australia. So I pay my respects to elders past and present. The women's health sector has a really long and rich history of supporting women through advocacy and service delivery to have reproductive choice. Last year, data from 14 of our women's health centres showed that pregnancy termination was a presenting issue for women on 555 occasions. So for the last 9 months, Women's Health New South Wales has been running a project alongside our members, of course, to improve access to abortion and also long-acting reversible contraception. So this project showed that despite abortion being decriminalised in New South Wales since 2019, access to publicly funded abortions is limited, and in some regions, it's just non-existent. So today, Dr. Erica Millar from Trobe University will discuss her paper on abortion stigma in Australian public hospitals, and she's also going to share her insights on how we can build environments that treat abortion as the fundamental healthcare that it is in our local area. So Erica, I'm going to stop talking and the floor is all yours.
Hi everyone, it's such a pleasure to be here. I'm finding that the older I get, the less I can multitask. So I'm just going to put my slides on, focus on that, and then I'll start talking. Okay, great. So I assume you can all see those slides. I just wanted to say thanks so much to Jackie, Sarah and Courtney at Women's Health New South Wales for inviting me to speak today and to organise the event. I can see how pivotal Women's Health New South Wales must be in the state, because there's so many amongst you. It's such a delight to speak in front of 30 health workers and advocates. So I am coming today from the lands of the Wurundjeri people. I'm at the Bundoora campus in Melbourne. Wurundjeri are the sort of central Melbourne and some of the suburbs, and the name derives from the manna gum tree that you can see there that's still dotted around the hills of Melbourne, and then the jerry, which is the bugs that you can find at the root system of those trees. And I'd like to pay my respect to the Wurundjeri people's connection to land, waterways and community, as captured here in this beautiful image by Wurundjeri activist William Barrack. And so over the past 4 years, it's been a huge amount of time. I've interviewed 51 health workers and advocates. You can see here a table of the people I've interviewed across Australia. So most of my interviews have been with health workers who either work in public hospitals or who have been involved in referring people who need abortions to hospital services. I'm very slowly writing these interviews into a book on the hospital provision of abortion services in Australia. And today I'm going to speak to you about abortion stigma. I will begin with a brief overview of how academics have defined abortion stigma before looking at how it manifested in some of my interviews. In this paper, I'm going to depart a little bit from how stigma is commonly examined, and that is as manifesting at the level of individual stigmatizers and stigmatized, and instead focus on how our health systems and health institutions can stigmatize abortion and abortion patients. This is the link to my article, an image of the only article I've written on this data so far, but they're coming slowly but surely. And so the most influential definition of abortion stigma came from Kumar and her colleagues in 2009, and she defines abortion stigma as a negative attribute ascribed to women who seek to terminate a pregnancy that marks them internally or externally as inferior to ideals of womanhood. So this definition points to the important cultural and social elements of abortion stigma. Women are generally expected to be instinctively nurturing, naturally fertile, and inevitably mothers. And ending a pregnancy transgresses these feminine ideals. So although Kumar's definition is still very influential, there has been a move away from thinking of stigma as a static attribute that one either possesses or imposes on others. So this definition has often led to an assumption that the best way to tackle stigma is by raising awareness of the effects of stigma or the old-fashioned stereotypes upon which it is based. Instead, scholars argue that stigma runs much deeper than merely attitudes and plays a role in organising and rationalising modes of social inequality. And so in this article, I defined abortion stigma as a socio-cultural process tied to the categories of difference upon which power relations are produced and legitimated. Stigma is one of many processes through which abortion is made intelligible or meaningful, and is always contingent, so it's always dependent on context, and it's always contexted. We live in, social context where there's always one meaning of abortion, and that meaning is not just stigma. A lot of us celebrate abortion as a necessary healthcare service, for instance, and these stigmatizing and more celebratory narratives coexist, and with also more neutral ones. So with this definition, as you see, I try to draw attention to the role of stigma in reinforcing dividing practices. And these dividing practices are the foundation of social inequality. And so, a classic dividing practice is that between men and women. So these dividing practices occur at the level of individuals, for sure. People stigmatise and are in turn stigmatised. People stigmatise and are also stigmatised, but they also work at the level of systems and institutions. So I just also draw your attention to this socio-ecological model of stigma. I think this is useful. Sorry, my camera was hidden there for a second. It's useful because you can see here all the circles. So we're the sort of micro, this is us as individuals. The meso is our immediate environments. And so the hospitals that I'm talking about would be meso in so much as it's a local healthcare facility. And our macro level stigma occurs at the level of our health systems and laws. And so before returning to my interviews, I'll just outline a little bit of work I've done on the law. I'm partly a socio-legal studies scholar, and I've written quite a bit on the decriminalised legislation. And through these pieces, I've argued that even after decriminalisation, the law continues to differentiate abortion from other forms of healthcare. So the dividing practices I've been interested in tracing through all these articles is between abortion and between other forms of healthcare. So while decriminalisation brought the regulation of abortion primarily from criminal law into health law, this wasn't complete. There's a residual of criminal offence for people who perform abortions without medical training. Abortion is regulated in a standalone act that places limitations on who can perform abortions, under what circumstances and in what facilities. So while these measures may seem commonsensical, what makes them exceptional is that all health services, as you all know, and the distribution of medications are already heavily regulated by a web of criminal, civil, administrative and disciplinary regulations and protocols. So this general health framework affords for the safety of patients and healthcare professionals and enables healthcare professionals to deliver evidence-based, patient-centred care without unnecessary obstructions. And so there's no standalone regulations for much more medically risky procedures. For example, no specific criminal law prohibits non-medical providers from performing tonsillectomies, for example, because such an offence is already covered under criminal law. So I think we need to always think, why is it the case for abortion? So let's turn to health systems now. Health systems also stigmatise. So as you know, abortion provision, particularly perhaps in New South Wales more than other states, primarily occurs in the private sector, in private clinics or the clinics of GPs who in Australia generally operate as private operators or independent contractors. So there's very little public provision through hospitals, and this is the subject of my research. There's, of course, exceptions. So this is so in New South Wales, in the Northern Territory, South Australia, and Tasmania, hospital provision is the standard way in which people get procedural or surgical abortion care. So the lack of public provision is an exception in so much as abortion is the only routine and common healthcare excluded from the public system. So in thinking about the pregnancy care that is provided through our public healthcare system, this system is structured around the birth of able-bodied children, in so much as public maternity hospitals, as we know, are required to provide antenatal and birthing services as a condition of their receipt of public funds. And if you're eligible for Medicare, you are entitled to care close to home. So this system is structured by dividing practices. So here we go back again to dividing practices between pregnant people who want to continue their pregnancies, whose pregnancy choices have the support of the state and by implication the community as a shared responsibility, and between those who do not, who must navigate services and pay for their own abortions. And so this is to my interview data now. This is how an obstetrician she was an MFM specialist, she put it. We provide maternity care without any question. But in contrast, we make women feel like we are doing them a favour by giving them a free abortion. I think I really never appreciated that difference in our attitude until someone mentioned it to me, and I thought, yeah, that's kind of still the attitude. The hospitals don't think they should be doing it because the person's not really sick. It's a woman's choice, so the attitude is that she should sort of be a consumer, I guess, and go off and pay for it. There is also a dividing practice between people who need abortions for fetal anomalies, who would generally find care through the public system, and those who want abortions for other indications. And as an OB-GYN, who I interviewed, put it, I hate the narrative of good girls and bad girls. So at the hospital where she works right now, the good girls can get their abortion. They have an abnormality, but the bad girls who are being abused, who have no money, who for whatever reason or just don't want to be pregnant, they don't get it. And so I do think we need to move away from that narrative, because any patient who wants an abortion should be eligible regardless of reason. No one is more deserving of an abortion than the other. I think we need to make sure that the woman is appropriately assessed, but at the end of the day, why does the good girl get it and the bad girl doesn't? So the state not only endorses this system of healthcare provision by abdicating responsibility for abortion care, but it is arguably invested in maintaining it. Public hospitals are already stretched to their limits. Absorbing new services into an already overburdened system does little to help, and only draws attention to the deeper need for a wholesale overhaul of healthcare funding. So there remains a distinct political unwillingness to confront this. So when we return back to stigma, we can see that stigma attaches to the services that the state does not support. Abortion is stigmatised, and although we can say this in a general sense, there is some acceptance that abortion in the second trimester and beyond for fetal anomalies need to take place. These are the later abortions that are spoken about more publicly and with sympathy and empathy. And they're also the abortions provided through the public healthcare system. We can see that this idea of the wanted pregnancy and the grieving mother is pertinent to thinking about the norms that are productive of stigma. While stigma can help justify the existing system, it also acts as barrier to change, obscuring inadequate provision as a recognised problem and preventing health departments from openly acknowledging and advocating for it without reservation. So this is in the words of an obstetrician gynaecologist in regional Victoria, who said whether it's health services or even health departments, people are just not really wanting to openly talk about what happens. Another key divide running through the Australian abortion care system is between those who can access care relatively easily, patients under 12 weeks gestation, living in cities, able to afford care through a GP or a private clinic, and those who cannot. A social worker at a large public hospital described how failures elsewhere in the system created a bottleneck at the hospital where she worked, forcing patients to navigate multiple referrals, endure lengthy wait times, and retell their stories at every turn. For regional patients in particular, the journey from confirming a pregnancy to accessing a free abortion can stretch to 6 weeks and longer. So this is from her. I see the biggest barrier in providing care at this hospital directly linked to the shortcomings of other providers in the state and how there's not enough funding and there's not enough access elsewhere. So then everybody in this is then in a bottleneck to come to where she works, and they have to endure more wait times, retell their story again. It's obstructive, it's inequitable, it's awful. And people attend here feeling really distressed, really judged. So I guess I'm calling attention here to the way in which our systems produce this feeling of feeling distressed and judged, because this is internalized stigma. Okay, so moving to institutions. Dividing practices are produced within hospitals themselves. These are inseparable, of course, from the systems that hospitals belong to. So one hospital CEO I interviewed described how even though the hospital he ran only performed abortions when the pregnant person's health was at risk, it was a reluctant participant in abortion provision. And even then, it participated only because it wasn't a frequent occurrence. I think there would probably have been some resistance if we were to have picked up the private sector's elective load. I think that would have been a different question. So his characterisation here of abortion as elective, his unproblematic relegation of them to the private sector, and his sentiment that the hospital only participated reluctantly, even in cases where the abortion was performed on serious health grounds, I think is not uncommon of bureaucrats working in hospitals and governments. The reticence of hospital management to agree to increased abortion provision within hospitals also stems from the systemic lack of provision. And this is going back to the bottleneck analogy of the social worker I quoted earlier. So this leads to an attitude amongst some hospital managers that, in the words of one obstetrician gynecologist I interviewed, we don't want to be seen as the termination capital of New South Wales, or don't want to open the floodgates, or there's this strange perception that women are just sitting there waiting for us to open our doors. So this floodgates analogy is a revealing one. Nobody argues against expanding, say, cardiac care on the grounds that it might encourage more people to come forward with heart problems. That this concern is raised in the context of abortion speaks to an implicit assumption that the demand for abortion care is inherently less legitimate than demand for other forms of healthcare. There's also, I think, an embedded judgment about the nature of that demand, that it is somehow disingenuous or at least negotiable in a way that makes institutional refusal seem reasonable. By fixating on the hypothetical risks of expanding provision, management actively distracts from the very real and ongoing risks of not providing care. And these are costs borne, of course, not by institutions, but by the patients themselves. And so this interview was with two obstetrician gynecologists who I interviewed together. And the exchange that followed is worth reproducing. And so one of them sarcastically mimicked how hospital management perceive women seeking abortion care. Speaking specifically here about care at advanced gestations. It's like, oh, great, I've always wanted a termination. And you can see that I've differentiated these two speakers in the quote, but I won't keep on referring to this differentiation. Yeah, there's this really strange perception. I think at the end of the day, people are like, there's this big thing where we want to not care for women outside of our service. But there's just not that many people having late terminations because nobody wants to be in that position. No, and maybe if we had made the first trimester ones easier, we wouldn't have them. Absolutely. But it's not like, even if the floodgates open, like 2 extra people a year, there's not that many people seeking them. No. And if there was, what were these poor women doing beforehand? So these health workers are unravelling lots of layers of stigma here. At hospital management's perception of abortion seekers as just waiting for the chance to have an abortion, about the systemic failures that force pregnant people into later gestation abortions, and then about the systemic denial of abortions to pregnant people who need them. Changing tracks a little bit, institutional stigma can manifest in abortion provision, providers not feeling valued for their work. As a social worker I interviewed at a large hospital commented, "This hospital publishes every year on its website how many babies were delivered, statistics of proud work. There is never mention of how many abortions we facilitated, never. It's an assumption that they wouldn't care. Maybe not that they wouldn't care, but maybe that it doesn't suit their branding." So I'm going to have a couple of quotes in the next slide that are about the way in which hospitals brand themselves. And I just randomly, this ad from the Royal Women's Hospital appeared on my feed on Facebook this morning. And I'm like, yep. And it constantly does. And you will all know that the Royal Women's Hospital is one of the biggest, the biggest public provider of abortion in Australia. And you don't really see that publicly celebrated. But it's all about, babies. Institutional stigma can also manifest in a lack of space given to abortion provision. So, for instance, in the place of formal abortion lists or the formal integration of abortion care provision into theatre lists of obstetrician and gynecologists, abortion patients can be placed on emergency lists. In such cases, patients are required to wait in the hospital fasting until their procedure and are routinely bumped, delayed, or rescheduled when higher acuity cases, such as emergency caesareans, take priority. As an OB-GYN I interviewed described, a lot of these are vulnerable women. They don't want to stay. They don't want to fast all day. They walk out. So I think such acts of walking out are caused by institutional failure to provide care adequately. And I mean, we could perhaps even read them as a resistance to stigma, and these women just say, "No, I'm not going to deal with this." From the standpoint of providers who are invested in getting these people care, it means that, and this is continuing this OB-GYN's quote, people are chasing them. It's like every aspect of trying to give this care creates more work for staff members who don't actually have the time and the resources to do the work. So this lack of resourcing for abortion work was a theme that ran through all of my interviews. So at one of Australia's largest hospital-based abortion services, patients are moved between 3 different locations on the day. Sometimes they wait for up to 4 hours on a barouche while their misoprostol takes effect. And this is a quote from a nurse who I interviewed who worked there. "Not having access to a toilet that they can just get up and walk to themselves, having to wait for us to be able to take them on a wheelchair. Hospital management have said there's no room to develop a dedicated space for abortion patients, yet managed to open a specialist clinic that would serve just a fraction of the patients that this abortion service provides care to." So this nurse continued that the opening of this other specialist clinic was celebrated as a positive news story. And whereas you and I both know that it's a positive news story to say that you've done that for abortion, and women that have abortions would say that too, they're not going to put that on the Channel 7 news, are they? So this is about branding. Another hospital provides a fortnightly public service, a fraction of what is required as part of an elective list off-site, a couple of kilometres away from the main hospital, which means, as one MF specialist said, if you're going to put your hand up to do that job, you sort of have to commit into doing a whole list. So it's a bigger commitment, and you don't have the surgical backup of other gynecologists on site. And that's a concern for some people who would otherwise be happy to help. When doctors attempt to establish or expand a service, they generally face delays and unwieldy administrative processes, attending endless meetings, developing business cases, modelling staffing and costing, writing protocols and addressing system-level questions such as what should be foregone so that abortion services can be added. One obstetrician or gynecologist I talked to who was in the process of trying to expand the abortion service she offered in a hospital. She described the pace of change as like molasses approaching a brick wall. That is, you do one meeting and then another meeting. And at the end of the meeting, I'm like, hang on a second, what did we talk about? What were the goals and when are we coming back? Stigma produces and rationalises this resistance to change and the perpetuation of hospitals as sites for the non-provision of abortion. Hospital-based health workers are pushing for change, but are often working against reluctant and often obstructive systems and institutions. There's a problem with individual obstructors for sure, but this needs to be located within the institutions and systems that allow them to occupy positions where their obstruction reverberates through entire hospitals and health systems. The crux of the problem, as one FM specialist I interviewed put it, is that abortion is not a service that people want to be built up and known for. You want to be the liver transplant unit or the trauma centre. You don't want to be the leading abortion care provider. There's nothing sexy about it at all. I think there's something sexy about abortion provision, but this is the common attitude. And again, this theme of branding and institutional branding, and also, what governments want to be known for as well, and build up their public profile for doing. Just briefly, I'm going to talk to you about some of the way in which the providers I spoke to spoke about the stigma facing abortion patients themselves. And I think you could probably hear that within some of the quotes I've already given you. So one obstetrician, a gynecologist I spoke to from regional Victoria talked about the cultural stigma, specifically in her community, and the way in which this impacts on the people she sees. So she says that if you have a group of people standing at a barbecue talking about whether abortion should be possible, who do these people think they're talking about? Who do those people think access abortion services? And I think there's a complete myth and misunderstanding that's all teenagers. It's that idea that it's someone else that needs to have access to termination services. It's someone else. It's not someone like me. That's sort of a separation. And then the people come into the consult room looking like they're being dragged into the headmaster's office and they're about to get into trouble. Another provider I spoke to looked, and this was actually a common theme. I'm just going to give you one quote of the way in which the people they've seen have already been stigmatised by other health workers. Of course, conscientious objection, obstruction of care is a classic example of this, but so is not treating patients properly and with care, and the patient's internalised sense that they're actually deserving of mistreatment. And so this obstetrician gynecologist at regional Queensland said that often she'll see people that haven't had any help with their vomiting and never sorted out. I think this is part of an internalised sense of this is a punishment. And finally, I'll just provide this quote from a health worker a social worker who talked about the way in which our structures stigmatise abortion patients. And this creates, according to the social worker, a sense of disempowerment where this might not be possible for me. I've been referred to maybe 4 different places and I still haven't been able to get an abortion. I've known about this for 6 weeks and there's so many barriers that can have pushback of feeling that I wonder what if it does to someone's sense of, am I worthy of care? Am I worthy of accessing support without judgment or stigma? And so this social worker is really talking about the way in which the people who come to her after trying to access an abortion for 4 to 6 weeks, often from regional, from the country, are feeling that they're actually not deserving of care, and so they feel incredibly grateful when they're treated with respect, as we all should be when we're seeking healthcare. And I want to just quickly look at the way in which some of the abortion providers I spoke to spoke about them as subjects of stigma. And I just start by saying that most of the abortion providers and health workers I spoke to actually said that they didn't feel stigma. But there was nuances to this. And so, for example, an obstetrician and gynecologist I spoke to who was just starting out in her career, she just become a fellow. She said that while she was training, and she wanted to, her aspirations had always been to be a specialist in abortion care. And she said that while she was training, a couple of senior obstetricians came to me and said, "Do you really want to be known as the abortion doctor?" And then another obstetrician gynecologist telling me that she delivers babies, but actually she gets she finds providing abortion care much more rewarding. And that's what she said. "I feel immense value in what I do, but to hear someone say, I get more value in doing abortions than delivering babies is really shocking for someone to hear." I think, alongside these feelings of stigma were a sense of real pride in work, in their abortion work. And so I'm quoting from this obstetrician gynecologist who sort of flippantly referred to himself as an abortionist, because alongside my interviews with health workers, I also read a lot of media and parliamentary debates where the term abortionist is generally used pejoratively. And so I sort of asked him about that. And he said, "So I probably wouldn't tell anyone I just met I'm an ONG and I'm an abortionist. I'll probably gauge them a bit before I would offer that. Friends and family all know I've never felt stigma. I'm reclaiming it. Why should there be a stigma associated with it? I would like to think that it would take away the stigma by using the word. We say out loud what we do." So abortion exceptionalism and stigma is ingrained, I would argue, in our healthcare system, which is at the same time under pressure because of decades of erosion of neoliberal healthcare policies. This context may call for top-down solutions, and these can work. Earlier in this paper, I excerpted from a former hospital CEO who characterised his hospital as a reluctant provider of abortion. The hospital where he worked now provides an abortion service as part of as part of Tasmania's overhaul of surgical abortion provision, which you might remember was to solve the dearth of provision of surgical services in the state. And so the Tasmanian government, obviously there was a lot of media interest in this issue, and the government acted by mandating 3 hospitals across Tasmania to provide procedural care. And a nurse who worked at the same hospital that the CEO worked said, when the government announced this policy in 2022, the reaction of the hospital was, "Quick, let's get it together." And everyone at the hospital has been really supportive. And we remember, I'm sure, the 2019 Labor promise to bring in free abortion care at public hospitals by tying public funds to hospital abortion care. They didn't win that election. They've conveniently forgotten that policy since. If there's a political will, there's a way. And, Tasmania proves that. Another option, and this is one that is advocated for by others, is the inclusion of abortion care into clinical service capability frameworks. So, for example, a level 1 or 2 service may be required to provide medication abortion, and level 6 service may be required to offer care for high risk and complex cases, as well as surgical second trimester services. So this would disperse abortion provision through the public healthcare system, require hospitals to actively recruit clinicians for abortion work, provide exposure to abortion provision to medical students and trainees, and ensure that the hospital's level provision is congruent with the skill set of its workforce. But at the same time, I think we need to explore other options. Obviously, there's a move to greater nurse and midwife provision of early medical abortion in the community and through community healthcare settings. And I think this is obviously, and I'm sure we all agree, a move in the right direction. But I think we can also imagine this for procedural abortions as well, which don't need to be performed in doctors under general anaesthetic in aseptic environments as they are in hospital settings. So I'm sort of thinking utopian possibilities here and what we need to be thinking about in the future. And in thinking through these things, I think it's really useful to go to the World Health Organization's guideline on abortion care. And I'm just going to excerpt a few of what they recommend for procedural care. And it can continue. It always refers to surgical abortions as a simple outpatient procedure. And it says that both forms of vacuum aspiration, i.e. manual and electronic, can be performed in primary care facilities on an outpatient basis. Like, this is way more radical than what we have in Australia. As you would expect, not only does it say that nurse and midwife provision is safe and effective, but that most patients prefer getting their care from nurses and midwives. And this option, it says, is not only feasible, but may decrease inequalities by extending quality abortion care to underserved populations. I'm just highlighting here the recommendation. You can see for surgical abortion, there's a huge range of medical workers that they say should be able to provide abortions. And it's interesting in Australia, when we're talking just about medication abortions, that we obviously only permit that for endorsed midwives and nurse practitioners, whereas the WHO would extend that to on a skills base. If you've got the skills, you should be able to do it to all nurses and midwives. And this is for procedural abortion care too, because they argue in WHO that if you can insert an IUD where you have to sort of navigate the cervix, you can do manual vacuum aspiration because it's sort of it involves the same skill set. Of course, you need additional training. And I just want to quickly think about sedation, and this is the World Health Organization. It's interesting. I did my PhD looking at a lot of historical archives on abortion. By historical, I meant like 70s radical feminists. And they were really, really critical of the turn that they saw at that time, which is the 1970s, toward general anaesthetic use for procedural abortion care, because it was the 70s, they were radical feminists, they were saying it's a way of keeping that relationship between the male doctor and the female patient one of subservience and passivity. So it's interesting that this is sort of normalised and accepted in Australia today. The World Health Organization recommends specifically against the routine use of general anaesthetic. It recommends, of course, we need pain management and conscious sedation where possible. Okay, so just wrapping up, I think that one way to normalise abortion care is to disperse it as much as possible. The sexual and reproductive health hubs in Victoria have been a really transformative example of the way in which governments can mobilise extant community healthcare centres for abortion provision. At the moment, they're doing great nurse-led work in both providing early medication abortion as well as referring patients to hospital-based surgical procedures, which have increased substantively and notably quietly over the last couple of years. And those of you who are familiar with the Victorian context would know that. And it's interesting that the government is not celebrating that as an achievement. It's just people in the know are very aware that hospital provision has probably doubled in Victoria over the last, say, 3 years. It's a quiet revolution. Of course, private provision is still the norm. And so I think we can think in the future of what if these services were also equipped, as the WHO guidelines suggest, to provide simple procedural care. And of course, I'm looking at you, Women's Health New South Wales, and all the community health organisations that are, amongst you, about the possibilities that, could open up in the future. And so realising this vision would require dismantling the stigma that has long kept abortion care siloed from mainstream healthcare services. So I'm going to end there.